Hello, wonderful people. It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my cardiology playlist. In previous videos, we talked about rheumatic fever, which affects the endocardium, the myocardium, and the pericardium of the heart. We also talked about cardiomyopathy, which affects the muscle layer or the myocardium. We talked about acute myocarditis, also affects the muscle layer. And we talked about pericarditis, pericardial effusion, and cardiac tamponade, and all of these are diseases of the pericardium. Today, it's endocarditis time. Itis means inflammation. Inflammation of the what? Of the heart. Which part of the heart? The endocardium of the heart. And the endocardium of the heart includes what? Includes the valves. So can I develop murmur? Sure. If it ends in itis, it means there is inflammation. Can I have fever? Sure. In fact, on your exam, any patient who is between 35 and 65 years old who presents with fever plus a new murmur has infective endocarditis until proven otherwise. Now click the like button, click the subscribe button, and let's get started. This is my cardiology playlist. Please try to watch these videos in order. This playlist will teach you about ischemic heart diseases, arrhythmias, murmurs, hypertension, CHF, cardiac tumors, and much more. To get the most out of this video, watch my video on rheumatic fever before watching this video. Back to basics, here's the wall of the heart. Inside layer, endocardium. Middle layer, myocardium, which has the cardiac myocytes or muscle cells. Outer layer, pericardium. What is the difference between the pericardium and the epicardium? Let me know in the comments. Endocarditis is a disease that affects the endocardium, including the valves. How about myocarditis, cardiomyopathy, myocardial infarction? They affect the myocardium for the most part. Then I have pericarditis, pericardial effusion, pericardial tamponade or cardiac tamponade. They affect the pericardium. But where is rheumatic fever? Rheumatic fever affects all three layers, pancarditis. But today's topic, which is endocarditis, affects the inner layers and the valves, so I can get a murmur. Is the murmur more likely to be stenotic murmur or regurgitation murmur? I mean, look at the E. It is regurg. We divide endocarditis into infective endocarditis caused by infection from microorganisms or non-infective endocarditis such as Liebman-Sachs endocarditis and non-bacterial thrombotic endocarditis. Liebman-Sachs endocarditis is seen in lupus, but non-bacterial thrombotic endocarditis is seen with cancers. It's a paraneoplastic syndrome. It's also known as marantic endocarditis. What the flip does that word mean? It means wasting away, from the Greek word marantikos. Oh, wasting away because I have cancer? Exactly. Cancer is the ultimate condition of wasting. Do you remember the word myelophthisis? Oh, it's a condition in the bone marrow that can happen by cancer invading my bone marrow. Exactly. And phthisis means what? Also wasting. Yes, cancer is the ultimate waster. It wastes you out. Both of these endocarditis are non-infective, which means the vegetations on my valves are sterile. They do not have any bacteria or any fungi. Liebman-Sachs is seen in lupus. It can damage valves, especially the mitral valve, most likely causing mitral regurgitation. As for the non-bacterial thrombotic endocarditis, this is a patient who has cancer, such as colon cancer or pancreatic cancer, and they secrete what? Mucin, because they have mucinous glands. And then before you know it, I have endocarditis in my heart. That's it for the non-infective endocarditis. The rest of the video will focus on the infective endocarditis. What kind of infection? Any organism can cause it, but common things are common. Bacteria win the story, hands down, are the most common, followed by fungi. Viruses and parasites are rare. So let's talk about the bacteria. We have acute bacterial endocarditis or subacute bacterial endocarditis. Which one do you think happens faster? Of course, the acute. And for this to happen faster, the bacteria has to be very strong. What do you mean? I mean high virulence. But the subacute is relatively low virulence bacteria. In fact, the bacteria that cause acute endocarditis are so strong to the point that they can damage even a healthy valve. Oops. But subacute usually require your valve to have a problem from before. Your valve was already weak. Came a weak bacteria and infected your weak valve. But if your valve was healthy and strong, you need a very high virulence bacteria to be able to conquer your valve. Whether I have infective endocarditis or non-infective endocarditis, the vegetations that we see on the valve surfaces can do what? Can dislodge. Oh, like an embolus. Exactly like an embolus. And then they go to blood vessels. Before you know it, they are all over your body. This is called embolization of vegetations. They are all over my body, causing tons of embolization symptoms. They trigger my immune system because these are foreign nasty little things made of bacteria or fungi, lots of debris, platelets, and fibrin. So they trigger my immune system, and I can also get immunological symptoms such as immune complex mediated glomerulonephritis, like kidney disease. Yes, and this is a very important thing because this can help you differentiate between endocarditis and rheumatic fever. Rheumatic fever had joint disease, skin disease, heart disease, brain disease, etc. But rheumatic fever did not touch my kidney. However, infective endocarditis, thanks to the immunological reactions to the vegetation dislodging, I can get what? I can get immunological symptoms such as glomerulonephritis.
But hey, medicosis, how dare you say that rheumatic fever does not touch my kidney? Haven't you heard of post-streptococcal glomerulonephritis?
Yeah, but that's a totally different disease from rheumatic fever.
But both of them are reactions to group A beta hemolytic streptococcus.
Yeah, but so what? They are two different diseases. The story of two adults who presented to you with fever and a new regurgitation murmur. What's the difference then? The first patient has history of trauma or bone pain or severe infection as in severe pneumonia. The patient is extremely sick. Contrast that with the second patient who has history of IV drug abuse and not so sick. We did a blood culture here and a blood culture there, and we found some bacteria. What is going on? Well, this patient has acute infective endocarditis. Look at how sick he is. But this patient has subacute bacterial endocarditis. So let's talk about bacterial endocarditis. First of all, you gotta know that most of the cases, like 80%, are caused by the staphylococci and the streptococci. We divide bacterial endocarditis into acute bacterial endocarditis and subacute bacterial endocarditis. Why do you call the acute acute? Because the bacteria are so strong, high virulence, to the point that they can damage even a healthy valve, and the patient will be very sick. What are the bacteria that cause this? The most common one is Staph aureus. Never ever forget this. It is very strong. Streptococci can do it, and Haemophilus influenzae. As for the subacute, the bacteria is less virulent. The valve was weak before we started the bacterial invasion. Or let's say I had an artificial valve or weak immunity, such as patient with chronic uncontrolled diabetes, HIV, etc. And this patient will be less sick as compared to the acute. What are the bacteria that cause subacute bacterial endocarditis? First of all, don't forget the same Staph aureus is also here. However, it's not the most common cause of subacute bacterial endocarditis. What's the most common then? Viridans group streptococci. Okay, but what if I did blood culture and the blood culture came back negative? Then odds are it's the Hasig group. Both of these two groups, whether the Viridans or the Hasig group, can come to me after an invasive dental procedure, especially if I have poor dentition and poor oral hygiene. Next, we have Streptococcus bovis. I like some bovis bovis, but they changed the name into Galolyticus, so now it's called Streptococcus galolyticus. Don't forget the Enterococci, also known as Group D strep. So endocarditis, what is going on? First, I am a patient with risk factors. What do you mean? I have poor dentition with poor oral hygiene, or there is an indwelling catheter in me, or I have weak immunity, such as chronic uncontrolled diabetes, such as HIV, as well as the congenital immunodeficiency syndromes. How about long-term hemodialysis? That's also a risk factor. How about a mitral valve prolapse? Also a risk factor. And this could be one reason why infective endocarditis in general is more common in females than males. How old is the patient usually? The average is between 45 and 65. However, it can happen to younger people than this and older people than this. Typically, female patients tend to be younger when they present with infective endocarditis, and male patients tend to be older. Or maybe I was hospitalized and they have indwelling tubes or catheters, such as an intravenous catheter or a urinary catheter. And then what? Then you should bring a blue pen and a red pen, and let's draw this. Here is the right side heart, and this is the left side of my heart. Amazing. Endocarditis in general is more common on the left side, hashtag mitral valve and not tricuspid valve. However, if the patient is an IV drug user, what's going to happen? Well, I'm injecting drugs into my veins. Veins will take me to the superior and inferior vena cava. Usually superior because I inject it to my arm most of the time. So the superior vena cava will take all of that gunk into the right side of the heart. Who's going to suffer first? Tricuspid or mitral? Tricuspid, of course. And I've just told you that the endocarditis is a regurgitation murmur, so I get tricuspid regurg if I'm an IV drug abuser. But for almost everyone else, they get left-sided infective endocarditis, so mitral regurg before any other valvular regurg. Okay, so mitral regurg is possible, tricuspid regurg is possible. What else is possible? Aortic regurg is possible. And you need to know how each murmur sounds like. Tricuspid regurg and mitral regurg are both pansystolic, high-pitched murmurs. The difference is that we hear tricuspid best at the left lower sternal border, but we hear the mitral regurg best at the cardiac apex, which is in the left fifth intercostal space mid-clavicular line. If that was too much, just half an inch below the nipple is way simpler. What happened to the cardiologist as he left medicine and started working as a bartender? Answer: he invented the twisted nipple cocktail. It reminded him of the left fifth intercostal space mid-clavicular line. As for the aortic regurgitation, it is diastolic decrescendo. Here is S1, here is S2. Where's diastole after S2? Aortic regurgitation will take all of the space right here to the point that you will not hear S2, and it will be diastolic and decrescendo, decreasing like this. Where should I hear this? At the A2 area. And where is that? This is the left third intercostal space, closer to the sternal border. Then what? Since we're talking infective endocarditis, give me those infected vegetations on my valve. First of all, how did they happen? Okay, they happened because of physics. Remember, in physics, we had two types of flow. There is the beautiful laminar flow, and there is the not so beautiful turbulent flow like this. When I have valves and pressures, and high pressure here but low pressure there, high pressure in the ventricle, low pressure in the atrium, what's gonna happen? Turbulent flow. And that's how you hear the S1 and S2 normal heart sound. You hear them because of the blood turbulence. Add to that the fact that this blood now has bacteria in it because of all of these risk factors. So before you know it, the bacteria are on the valve thanks to the blood turbulence. They will latch onto my valvular surfaces. And then what? They will destroy the valvular leaflets, and they can even destroy the chorda tendineae, which are attached to the papillary muscles. And when we destroy the chorda tendineae muscle, what do we get? We get regurgitation murmurs. And that's why murmurs of regurgitation are way more common than murmurs of stenosis in cases of endocarditis, because we damage the chorda tendineae muscle. See, medicine makes so much sense once we understand what the flip we're talking about. So, in a nutshell, any patient who comes to you on your exam day, who is between 35 and 65 years old, with fever and a no regurgitation murmur, has infective endocarditis until proven otherwise. Which means we will need blood culture to find the bacteria, and we'll need echo to look at the vegetations of the valve, as well as the valvular disorders, such as mitral regurgitation. What else is in the vegetations other than the bacteria? Well, we have bacteria, we have debris, we have inflammatory cells, and don't forget the platelets will come by, because the platelets see an injury, so they will stick because they have adherence capabilities. And we have learned about how to make a platelet plug in my playlist called Bleeding and Coagulation. Platelets are primary hemostasis. Then who's gonna come after this? Well, secondary hemostasis, meaning fibrin fibers will also come on the valve surface. Now we have a piece of gunk. stuck onto your valve, causing all kinds of trouble. Then what? Many of these vegetations can now embolize like an embolus, and they will go to blood vessels, and the blood vessels will take them everywhere. If this happened on the tricuspid valve, which is less common, I can go where? I can go to my lungs, to the pulmonary artery, and then to the lungs, giving me symptoms very similar to pulmonary embolism. But if this happens on the mitral side, which is the more common, I will go everywhere. I can give you emboli in your brain. I can cause emboli into the kidney. I can cause embolization into the skin, such as splinter hemorrhage, Osler nodes, Janeway lesion, splenomegaly, and much more. Moreover, when all of this gunk is now spreading to my blood, such as bacteria, such as debris, platelets and fibrin, all of this gunk will trigger my immune system, giving me immunological phenomena, such as immune complex mediated glomerulonephritis. How do I treat bacterial endocarditis? Antibiotics, of course. First, you take 3 sets of blood culture within the first 24 hours. Then you give the patient empirical antibiotics. We have no idea which bacteria caused it so far, but based on previous experiences, empirical data, we can say, you know what, giving vancomycin sounds like a good idea. Or giving ampicillin plus gentamicin sounds like a good idea. So you give the antibiotics and wait until the culture results come back. Once the culture results come back, now they will tell you exactly who's causing this. Oh, it was actually Staph aureus. Then you give antibiotics to target the Staph aureus only. Or wow, it was actually viridans. So you cover the viridans with antibiotics. Empirical therapy before the culture results. Targeted therapy after the culture results come back. Who else is going to explain endocarditis to you like this? Your freaking professor with his PowerPoint? Give me a break. Don't forget that these bacterial infections, the vegetations on the valves, can embolize, leading to bacteremia and pyemia. Pyemia does not mean that pus is floating in my blood. That's a terrible mistake the students make. Pyemia means there is a septic embolus, which means there was a focus that embolized, and this septic focus is now a septic embolus cruising through the bloodstream until I cause an abscess in my target organ, such as abscess in my lung, empyema in the pleural cavity, or brain abscess, etc. The following table is very important for your exam and for real life. If the question mentions that the patient has history of dental procedures and poor oral hygiene, poor dentition, then the organism is likely viridans group Streptococci. This is not one bacterium. This is a group of bacteria, including many. The most famous ones, Streptococcus mutans and Streptococcus mitis. Because here's what happens to students during the exam. They look at dental procedures and say, aha, it's viridans group. Then they look at the answer choices. They say, well, there is no viridans in the choices. The professor made a mistake. No, look for Streptococcus mutans or Streptococcus mitis because these are members of the viridans group. What if the question told me that there was dental procedure with poor dentition, however, the blood culture came back negative 3 times? Well, this is probably the Haysick group, which can lead to endocarditis, but it's culture negative endocarditis. If the question mentions IV drug abuse, Staph aureus is the most common, followed by Pseudomonas, Candida, and Enterococci. If the question mentioned the patient has artificial heart valves, well, try to specify how long since the valve got installed. Let's say the valve was placed 20 days ago. Oh, there's going to be Staph epidermidis, or Candida, or Haysick. What if it was longer than 60 days ago? Then it's Staph aureus or Enterococci, which is group D Streptococcus. If the patient is hospitalized, look at the catheter. Is it intravenous catheter? Then it's Staph aureus. Or is it indwelling urinary catheter? Then it's Enterococci again. Remember from microbiology that Staph epidermidis and Enterococci had what? Had adherent biofilms, thanks to their slimy layer in their structure. That's how they can adhere to your artificial valve or to adhere to your IV catheter or indwelling urinary catheter. If the question mentioned history of any colon ulceration, What do you mean? I mean ulcerative colitis, which is an inflammatory bowel disease, or colon cancer, because this can also ulcerate. Ulceration, hemorrhage, necrosis, you name it. Then what's the organism? Streptococcus bovis or Galolyticus? If the patient is immunocompromised with chronic indwelling catheters and prolonged antibiotic use, bacteria are possible, but don't forget that fungi are also possible. It's called fungemia when the fungi are in the blood, and bacteremia when the bacteria are in my blood. Infective endocarditis with positive culture versus infective endocarditis with negative culture. What kind of culture are we talking? We're talking blood culture to try to detect the organisms. If it came back culture positive, probably Staph aureus, very dense group, Staph epidermidis, Enterococci, Streptococcus galolyticus, or Candida. But if the culture came back negative, i.e. culture negative infective endocarditis, it's the Haysick group. What does that mean? It's an acronym. The H is Haemophilus, the A is Aggregatibacter, the C is Cardiobacterium hominis, the E is Eikenella, and the K is Kingella. Who named these things? Culture negative could also be Aspergillus. If the question said dental or periodontal disease or infection, think Haysick. If the question said artificial valve, think Aspergillus. If the question said unpasteurized dairy, think Coxiella burnetii or Brucella. If the question said an immunocompromised person who came in contact with cats or who is homeless, then it's Bartonella henselae. Exposure to birds like parrots, Chlamydia psittaci, contaminated water sources, air conditioning units, Legionella, and the Whipple disease is Triphorema whipplei. They also love to test you on microbiology, so they might say coagulase positive, catalase positive, gram positive coccus instead of just saying Staph aureus. Or they can say coagulase negative, novobiocin sensitive, catalase positive, gram positive organism instead of saying Staph epidermidis. Or they can say uptokin resistant alpha hemolytic gram positive bacteria in chains instead of saying viridans. Or they can say gamma hemolytic, meaning no hemolysis on blood agar, bacteria that can grow in 6.5% salt solution. This is Enterococcus. How about the one that causes no hemolysis but cannot grow in salt solution? This is Galolyticus or bovis. Do you remember my first question that I asked today about the difference between patient A and patient B? Patient A had very severe endocarditis, but patient B has less severe endocarditis. Patient B was an IV drug user. Why do IV drug users get a less severe endocarditis? Because this goes to the veins and then to the right heart, which is a very slow process. And there is no history of wound infection, septic arthritis, or osteomyelitis, making the case less severe compared to another patient who has history of wound infection, septic arthritis, or osteomyelitis. Quick review of some organisms. Staphylococcus epidermidis, don't forget the mechanical valves, whether in the heart, joints, and don't forget they can also trigger an immune complex glomerulonephritis, and this is an immunological phenomena in bacterial endocarditis. How are they adherent to these valves and to these prostheses? Because they have a slimy layer, biofilm. Next, the Galolyticus, formerly known as Streptococcus bovis. You know why we call it Galolyticus? Because it breaks down methyl gallate. When the question mentions any history of colon ulcerations, such as ulcerative colitis or colon cancer, or even liver disease, think Streptococcus bovis. Very dense group Streptococci is not one bacterium, it is many, including the mites and the mutans. These are the most common. Also Streptococcus angiosus, salvarius, even bovis could be considered one of the group, and Streptococcus suis. As for Enterococci, they also adhere to catheters and prostheses, and they form biofilms. They can lead to urinary tract infections because of the urinary catheter, peritonitis, endocarditis with persistent bacteremia. Streptococcus viridans alpha hemolytic, think of dental infections or dental procedures. Enterococci, think of indwelling catheters, prostheses. It is gamma hemolytic, meaning no hemolysis, and there should be history of urinary tract infection or indwelling urinary catheters. Streptococcus galolyticus or bovis is also gamma hemolytic, think of colon cancer or ulcerative colitis. Let's summarize everything we've learned about infective endocarditis. The patient is between 35 and 65, give or take, most common in females than males. Risk factors include congenital heart disease, mitral valve prolapse, poor dentition, dental procedures, IV drug abuse, artificial heart valve, the prostheses, colon ulcerations, whether it's ulcerative colitis or colon cancer, nosocomial endocarditis, such as IV drug catheter or indwelling urinary catheter. It's the turbulence that triggers the valve damage. Platelets and fibrin will come trapping the circulating bacteria or fungi. Before you know it, I have my vegetations. They damage the valve leaflet, they damage the chorda tendineae. That's why I get a regurgitating new murmur, such as mitral regurg most of the time, or tricuspid regurg if I have IV drug abuse. Fever and murmur, murmur and fever. Fever and murmur, murmur and fever equals endocarditis. Of course, this murmur has to be new murmur that did not exist before. It's endocarditis, itis inflammation, so I have neutrophilic leukocytosis. If I have fungal infection, it could be lymphocytic leukocytosis. Symptoms are many, including fatigue, failure to thrive, joint pain. In my retina, I have Roth spots. In my kidney, I have immune complex mediated glomerulonephritis. In my vessels, immune complex vasculitis. That's probably why I have Roth spots in the retina. Instead of saying Roth spots, your question might describe them as irregular red areas with central white dots. Skin problems, splinter hemorrhage, Janeway lesions are painless, but Osler nodes, look at the O, ouch, they are painful. Infarcts all over the body thanks to the embolization, septic emboli, splenomegaly, and even neurological symptoms. How can we diagnose infective endocarditis? Clinically, of course, history and physical exam. You gotta get me 3 sets of blood culture before you start antibiotics. Acute bacterial endocarditis usually has high neutrophils, but subacute usually has monocytes, and this is good old pathology. Remember that acute inflammation is neutrophil land, but chronic inflammation is macrophage land. Who is the macrophage? But the circulating monocyte. When they are in the blood, they are called monocyte. When they are in the tissue, they are called macrophages or histiocytes. When they are in the liver, they're called Kupffer cells. When they are in my brain, they're called the microglial cells. See, medicine makes so much sense once you understand what the flip you're talking about. Believe it or not, rheumatoid factor is positive in many cases with infective endocarditis. Since this could be subacute or let's say semi-chronic, I can have anemia of chronic disease. Echo is very important. TEE is better than TTE, which means put the echo probe into the esophagus, not onto the patient's chest. What am I trying to see with the echo? The valvular heart disease and the vegetations. If I biopsy these suckers, what's in the vegetations? I have bacteria or fungi, I have fibrin and platelets, and lots of inflammatory debris. Treatment. First, draw the 3 sets of culture. Then give empirical antibiotics based on your best guess of the patient's history and physical exam. You can give vancomycin, you can give penicillin, you can give ceftriaxone and gentamicin. And then the culture will come back with the accurate result. Oh, it's actually Streptococcus mitis that caused this. Then you target the Streptococcus mitis. But what if the cultures came back negative? Oh, negative could be many things, including the HASIC, including Bartonella, Coxiella, etc. So what do? Give something very broad spectrum, such as the combo of ampicillin plus gentamicin, which is a very important combo for infective endocarditis. What if everything hits the fan and the patient is not responding to treatment? I have symptoms of acute heart failure, or the infection is spreading like mad, causing lung abscess, empyema, brain abscess, etc. Then it's time to do surgery to remove these vegetations. What are the possible complications of infective endocarditis? We have local complications and global complications. Local mean in the heart. I can have abscess in the heart. I can have heart failure. I can have pericarditis. I can have fistulas inside the heart. Distant complications means outside the heart, such as septic emboli, such as mycotic aneurysm. What does the word myco mean? Mycology means fungi.
Oh, so you're saying that mycotic aneurysm has to be a fungus?
No, it could be any organism, so a better term is infected aneurysm. The abscess can metastasize, we call this septicemia, and pyemia. Organ infarction, brain abscess, meningoencephalitis, vertebral osteomyelitis similar to pot disease of tuberculosis, and septic arthritis. If you want to download these doozy colorful notes, go to my website medicosisperfectionalis.com. If you remember rheumatic fever, we had the Jones criteria for rheumatic fever. As for infective endocarditis, we have the Dukes criteria. Now they have been modified. The modified Dukes criteria are many. This is not a comprehensive list. What are the major criteria? They hover around two things: positive blood cultures for typical organisms like Staph aureus, like the very dense group, like Enterococci, as well as a positive findings on echo. What do you mean by positive findings? The freaking vegetations. Don't forget that transesophageal echo is better than transthoracic echo. Having an abscess is another major criterion. How about the minor Dukes criteria? Fever, predisposing heart lesion. What do you mean? I mean a prosthetic valve. How about IV drug abuse? How about embolic phenomena and immunological phenomena? These are minor criterion. In order for you to say that this patient definitively has infective endocarditis, you need two major. For example, positive blood culture, positive echo findings, or positive echo findings and an abscess. Or if you just have one major, you need one major plus three minor. What if I have one major and one minor? It's possible. What if I have three minor? Possible, but not definitive. Do you want to learn about penicillin, vancomycin, ceftriaxone, gentamicin, amoxicillin, etc.? Then download my antibiotics course on my website medicosisperfectionalis.com. It will teach you about antibacterials, antivirals, antifungals, and antiparasitic medications. If you want to learn about the different types of shock, cyanotic and acyanotic congenital heart diseases, then download my surgery high yields course at medicosisperfectionalis.com. There are more than 1,600 free videos on this channel, plus 300 videos that are only for those who click the join button and choose the highest tier. Please subscribe, smash like, and hit the bell. Support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.